In the past recent years, you must have heard that our global population, we are suffering a slow epidemic of obesity. We are seeing an uprising trend in the cancer incidence and morbidity. We are seeing an epidemic of diabesity. Diabesity is diabetes and obesity. We are seeing more number of coronary artery disease, and deaths due to coronary artery disease are highest in a country like India for young population. So with so many things in hand, let us come and learn, and let's see what you need to remember for your MCQ exams from non-communicable disease chapter about prevention, and what are the things you need to remember and the national health programs associated with that. Let's start with the first topic to understand what is a national non-communicable disease. Non-communicable disease will be a disease which does not communicate. So therefore, it is usually non-infectious. But there are certain situations like rheumatic heart disease which could even have an infectious etiology. So non-communicable disease is essentially a disease which does not communicate from person to person. But it is said that if I live in an area and I'm eating a lot and I have a bad lifestyle, there are high chances that people in my house also will start adopting that same bad lifestyle. And if I'm working a lot, if I'm jogging every day, if I'm doing cycling every day, even my neighbor would see that, look, he's jogging and cycling every day. They adopt a healthy lifestyle. So I kind of disagree on this, but that's how the notion is, that it's a non-communicable disease. And on the other hand, infectious diseases would essentially be communicable. But anyways, for your MCQ exam, please understand this is a non-communicable disease. Why did I spend so much time on just this point, non-communicable disease? Try to understand that there is a risk factor which causes a disease. Simple. The point to be understood is that the risk factor, whenever it enters into the body, the point from the entry of the risk factor to the causing of disease, this time is pretty long. It's a very long time till that time we get the disease. Cancer, there's a long history of risk factors, right? This time period is called as incubation period for communicable disease, and non-communicable disease, we call this as a latent period. So please understand point number, MCQ number 1, what is a latent period? Latent period is from the entry of the organism, or in this case, entry of the agent, that is the onset of the risk factors, till the time of first sign and symptom. It is from the entry of agent, that is the risk factor, till the first sign and symptom. First sign and symptom, that is what is called as the latent period. First MCQ. Second point, what do you mean by a chronic disease? Chronic disease is a disease that is classified by WHO. Chronic disease is a disease which has irreversible pathology, with alterations in your body, for a long time. And that's how the MCQ in AIMS people, they picked up how much a long time. Technically, we don't have a number, but grossly speaking, the number is anything which lasts for more than 3 months is generally used as a chronic disease. That was your point number 2 to remember. Point number 3. What is a WHO STEPS performer? There is a WHO STEPS performer or a STEPS approach. What is this WHO STEPS approach? It is for non-communicable disease surveillance. This WHO STEPS approach is based on first MCQ. It is based on a questionnaire assessment. If the patient is saying, or the person says that, yes, I agree to most of the questions, or they fall into that category, then we will do the anthropometric measurements. We will do the physical examination of the patient. We will check the height, weight, and other indicators of the body. And in case the patient falls into that category of higher anthropometric measurements or bad risk factors or high risk factors, we have to go to the level 3, that is the laboratory investigations. So this is what is the WHO STEPS approach. With that, let us start with the first topic of the day, that is coronary artery disease. What are the prevention strategies in the coronary artery disease? See, I'm not going into the clinical features of coronary artery disease or the pathophysiology of that. That will take me years to tell to you and discuss with you. I think our learned faculty from medicine, they have done beautifully this job about coronary artery disease, pathology. So these are the areas where you would integrate your medicine with. Over here, I would like to talk to you about the prevention modality a little bit more in detail. The prevention for cardiovascular disease or the coronary artery disease could broadly be classified into different types of strategies. So we can have a prevention strategy. The prevention strategy for coronary artery disease could broadly be classified into three classes. We can have a population strategy. We can have a high risk strategy, or we can have a secondary prevention. The population strategy or the high risk strategy, these are essentially, like, not categorically, don't quote me on this, but these are essentially types of primary or primordial preventions. The population strategy could further be classified into a primordial prevention, or it could be a primary prevention, typically talking specific protection. Specific protection. So let's talk about this population strategy now. If you talk about the population strategy, as we already discussed, it's of two types. We can have a primordial prevention, or we can have a specific protection. This specific protection is MCQ. It's a type of primary level of prevention. Primordial prevention in combating coronary artery disease. We don't want to go into much detail because these are very generalist terms you will be hearing. So how would you do a primordial prevention? It is to improve the physical activities of the children. So who are in school? So school going children or adolescent children, you improve their physical activity. You promote the sports days and all these things. You have a smoke-free society. So we can make some guidelines, we can make some laws like that. You might need to generate the awareness regarding weight control so that people don't fall into the trap of heavy weight or excess weight or overweights. So these are generally your primordial prevention. Talking to your MCQs now, specific protection. Specific protection means specific dietary changes. So coming now to the dietary pattern, or what are the dietary recommendations. The dietary recommendations for combating coronary artery disease. The dietary recommendations for combating coronary artery disease is less than 20% fat intake. We also need to have less than 5 grams of salt per day. Salt per day should be less than 5 grams. The cholesterol intake should be less than 100 milligrams per 1000 kilocals per day. There should be prohibition of alcohol and prohibition of smoking. So these are some of your dietary changes. Beyond this, what are the guidelines for dietary changes or for the laboratory values? The total cholesterol in a person. The total cholesterol should be less than 220 milligrams per deciliter. The total HDL in a person should be more than, right? HDL is a good lipid, right? It should be more than 40 milligrams per deciliter. And the total cholesterol to HDL ratio should always be less than 3.5. So that's the targets that we want to achieve in the population in case we want to have combat the CAD. To achieve these targets, these are the dietary guidelines that we have. So 20% fat, salt and cholesterol, and no alcohol and smoking. So these are your, specifically we have talked about the specific protection. Going back, so what we have talked till now is primordial prevention, that is the generalist thing. We talked about the dietary guidelines under the specific protection. Let us talk about the high-risk strategy. What are the MCQs in high-risk strategy? So high-risk strategy is basically a primary prevention. That is, the person already has the risk and you want to prevent the disease. So who are the persons who will be under the high-risk strategy? So in the high-risk strategy, you need to remember that what are the high-risk strategies. If a person is a smoker, you ask him to stop smoking. So to quit smoking. So it is different from not starting smoking and quitting smoking. Quit smoking in a person who's already at risk. Then is treatment of hypertension. See, I understand hypertension can be taken as a disease, but under this program, from the view of the program, the name of the program is coronary artery disease, cancer, diabetes, and stroke. Right? So diabetes, coronary artery disease, and stroke all are caused by a risk factor, that is hypertension. So hypertension is essentially a disease. I fairly agree with you. But from the program eyes, this is a risk factor. So that is the reason we're saying that the high-risk strategy would be patients with risk factor, they should decrease that. So treatment of hypertension, don't do this mistake in the exam. Treatment of hypertension will not fall into a secondary level prevention. It will fall into a primary level prevention. And that's the reason many times it gets stuck in the MCQ exam. On the same principle, if you understand about hypertension, I would like to tell you that you also need to know that treatment of dyslipidemias or treatment of hypercholesterolemias or all things like this. So treatment of dyslipidemias, treatment of obesity, treatment of hypertension, we have already talked, treatment of cholesterol, hypercholesterol or increased cholesterol. All this treatment would be taken as treatment of the risk factor, and the patient would fall into a high-risk strategy. What is high-risk strategy? It is essentially a primary level of prevention. So we have covered the high-risk strategy, which is primary level. Now let us come to secondary level. What is left out? Secondary level prevention means that the patient already has a coronary artery disease. See, the topic name is CAD. So patient already has a coronary artery disease and you are going to do secondary prevention. That is, you are going to do angioplasty, or we are going to do bypass, or we are going to do some cardiac intervention. So some interventional cardiologists would come into play. So all these things, reperfusions and all these things, these all would come under the secondary level prevention. So these are specialized preventions which are difficult for our country to offer. What is best and easiest thing for us to do is do yoga every time. That is what is a population strategy for combating coronary artery disease. Next is, what are the typical studies which can be asked to you in the MCQ exam? So there are a group of studies which you need to remember. First is Framingham Heart Study. So Framingham Heart Study, MCQ on these, one line. Framingham Heart Study is the largest cohort study. It is the largest cohort study to study the association of the risk factors and happening of the coronary artery disease, not specifically coronary artery disease, of any heart disease. So heart disease, which included the heart failures, they included the coronary artery disease, of course, that was the main component, and risk factors, which were the main risk factors which were studied. After this only we came to know that obesity and hypertension are one of the most risk factors, biggest risk factors for causing coronary artery disease. Next is monitoring trends and determinants in cardiovascular disease. The interesting name for this is, it is fondly called as the MONICA. So the study name is a MONICA study. It is monitoring, MONICA, from cardiovascular. So it's monitoring the trends and determinants in cardiovascular disease. So technically speaking, it's just about the trends of heart disease in the whole world. So it's not Indian system, it's a global system monitoring trends and determinants in cardiovascular disease. Next is Oslo Heart Study. It was from Norway. So in Oslo Heart Study, the only thing that you need to remember, it's talking about the smoking and prevalence of coronary artery disease and its association with coronary artery disease. Stanford 3 community trials. So the focus is on the word community. It was a trial which was to see the effect of the health education on coronary artery disease. So that's a wonderful thing that you see that if you do health awareness and health education camps, does it have effect on people? Do people listen to you? Next is North Karelia project. North Karelia project was primarily on smoking, on hypertension, and on cholesterol, the effect and the association with coronary artery disease. So they were comparing all these main risk factors in the North Karelia project. Last is MR-FIT trial. These are called as the MR-FIT trial, and these have a potential for it to come in your exam. MR-FIT was the largest multiple risk factor trial. Its name is multiple risk factor trial, and it was multicentric trial. It is based on assessment of serum cholesterol, very important type of study, and many things we came to know from MR-FIT trials. The diastolic hypertension level cutoffs, the pattern of smoking, the type of cigarette, the pattern of smoking, and their association with coronary artery disease. This is one of the most important, and very frequently they will ask you about the multiple risk factors. Just recently, a couple of years ago, they had asked about the Monica study. So you just need to go through that. What are these study designs, or what are the things that you need to study in coronary artery disease prevention. Next is couple of things about hypertension. Let's talk about hypertension as a disease or as a major risk factor. It is a major risk factor for development of coronary artery disease, right? That's simple, important. What do you think is the burden of hypertension in India? Unfortunately, we know that 15 to 11%, 11% in females and 15% in males is the prevalence of hypertension in India. This is as per the NFHS4. NFHS4 data tells you about 15 and 11. The classification that we use in hypertension is very different. So I may be telling you one classification, medicine might be telling you another classification, and another subject might be telling you another classification. Under the National Program for Control of and Prevention of Cancer, Diabetes, Coronary Artery Disease and Stroke, that's a long name. The classification that we take is we use as a European Society of Cardiologists and European Society of Hypertension 2018 cutoff guidelines for hypertension. So this is the guideline that we are using. So just off the record, just to show you what is the cutoff. Of course, you don't need to memorize these numbers, but you should at least be knowing what is a hypertension. Hypertension would be anything beyond 140. High normal is 130 to 139 systolic and 85 to 90 as diastolic. Beyond these numbers, it's all grade 1, grade 2 and grade 3 hypertension. Right? So coming back to our story about hypertension, if you want, you can memorize these numbers. That's the classification that we are using under the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease and Stroke. It's a long name program. We will discuss this program at the end of this session. Don't worry. And that's the reason I have written only in abbreviations. So the classification that we are using is a European Society of Cardiology and European Society of Hypertension 2018 classification. The next point you need to do is what is a rule of halves in hypertension, and we will talk about what is tracking of hypertension. So these are two important things. Rule of halves is very simple. It is said that out of the total community, if let us say that this many people are hypertensive, let us assume that these many people are hypertensive. So people who are hypertensive, out of them only 50% will actually know they are hypertensive. So of all hypertensive patients, only 50% they are diagnosed. 50% are diagnosed. Out of all the diagnosed, only 50% are treated. Out of all the treated, only 50% comply to the treatment and adequate treatment is there. Adequate treatment is there. So out of all the hypertensive, only 50% know that they are hypertensive. All those know, only 50% take treatment. Of all those take treatment, only 50% are nicely treated. So that is the rule of halves, and that increases the burden of hypertension in the community. Next is what is tracking of hypertension. I ask you, just pause the video and think on this. You give me an answer. Speak it aloud, write it somewhere, but do write it. Do answer it. What do you mean by tracking of hypertension? I have two options. Tracking is that you keep a track of hypertension. That this is my BP in the morning, evening, morning, evening, morning, evening. One is tracking. So you track what is the level of BP that you have every day. Second way to see this track word is that there is a track, a rail track, right? There is a track, and on this track only I will keep my BP. So as my age will go, there is a track that we have made, and I will ensure that my BP falls into that same track and it follows a track. So obviously, I think you all know that now the second example was the meaning of tracking. Tracking means you keep the low BP as low BP. What do you mean by tracking of hypertension? Tracking of hypertension means that the low blood pressures should essentially be kept under check. So children who are young, they will have normal BP. So at that young age, if we develop a habit in those children that you should not do this, you should not do that, you have a good lifestyle, so that your BP is under check, probably at the very early stage, they are going to follow the same routine all their life. So it is done in which children? It is done in essentially school-going children. It is done in all school-going children. So we are keeping a check on their BP so that it remains under less only. Tracking of hypertension is what a level of prevention. It is technically grouped under the specific protection high risk strategy. It is grouped under the specific protection high risk strategy. Why high risk strategy? So because we think that the children would be already at risk of developing hypertension, we are keeping a check to keep that at level. So remaining, I think that's very easy for you to do. What is hypertension? Hypertension is higher blood pressures. What is the levels of prevention? You can have a primary prevention. You can have a secondary prevention. What do you mean by secondary prevention? If you recall your lecture on concepts of health and disease and epidemiology, in that concepts, we had talked about levels of prevention, right? So what is a secondary prevention? Secondary prevention is when the disease is there. Mark my words, when the disease is there and you stop the complications from occurring. So secondary prevention is when talking of hypertension as a disease now. So if you're talking of hypertension as a disease, early diagnosis of hypertension and its treatment would comprise the secondary level prevention. What is the primary level prevention that we have done already? That you do weights, you do exercise, you do weight monitoring, you do good food, balanced diet, healthy diet, yoga, all these things. So lifestyle modifications for primary level. So don't argue or don't confuse yourself. I would say don't argue with me. That's fine. I must be speaking in a tablet right now. But don't confuse yourself. That sir said lifestyle modification is a primary level. Why is not lifestyle a primordial also? I already discussed this controversy a couple of times on different platforms, and we have discussed it in the concepts of community medicine level of prevention where we discussed. There also we have already discussed that. Please understand there is considerable overlap between primordial prevention and primary prevention. So if a person is doing some lifestyle modification, he is doing some exercise at my age, let us say my age is 35. Okay. I'm not telling my age. So let us say anybody's age is 35 and they are doing let us say my age is 50 years. Of course, I'm not 50. Let us say a person would do exercise at an age of 50 years. Of course, this person is at risk of developing cardiovascular morbidity. So now he's doing exercise. That is essentially a primary level of prevention. But let us say you are just 22 years of age or 20 years of age. And if you're doing exercise and you're doing jogging, probably at this stage, you're not at cardiovascular risk. Assuming that you are not at cardiovascular risk, if you are doing, you would be doing that same activity as a primordial prevention. So there is a considerable overlap. But from program perspective, what are the things you need to remember? That lifestyle modification and doing exercise, physical exercise, having healthy diet and jogging and everything, these are all primary levels of prevention for hypertension. So the third topic that we are going to take up is obesity. Obesity means overweight, right? I don't need to explain to you what is obesity. MCQ number 1. What are the indicators for obesity? The first indicator you need to do is Quetelet index. What is Quetelet index? It is a BMI. BMI stands for the body mass index. The body mass index is given by the formula weight in kilograms divided by height in meters square. Height in meters square. The second indicator that you need to do is a ponderal index. Ponderal index. Ponderal index is given by the formula height in centimeters divided by cube root of the weight in kilograms. Weight in kilograms. Cube root of the weight in kilograms. Third is something called as a Broca's index. Broca index. It's not that the Broca area. It's a Broca's index. It is one of the most commonly used index. It is one of the most commonly used index. It's a general indicator. Of course, body mass index is you calculate everywhere. Both Broca's and body mass are very commonly used. What is the formula for Broca's index? Broca's index is given by height in centimeters. minus 100. So whatever, let us say your height is 175 centimeters and you want to check whether you are in approximate weight or not. So 175 minus 100, that would give you a 75. So your ideal weight should be 75. That is what is Broca's index. Next is, what is a Lorentz formula? Lorentz formula, or it is actually a correction of the Broca's index. It is height minus 100, that is what is the Broca's index, minus height in centimeters minus 150. Height in centimeters minus 150 divided by 2 or 4. 4 in case of males and 2 in case of females. So this is called as Lorentz formula. It is a correction of the Broca's index. Most commonly we either use the BMI, that is body mass index, or we use the Broca's index. I don't have space, so I need to change the place. I need to change the screen. We can also do another indicator, that is a corpulence index. Corpulence index. So just remember, corpulence index is actually not an index, it is a ratio. It is nothing but the actual weight of a person. Let us say I am weighing 90 kgs. My weight should be 70 kgs. So it is my actual weight divided by the desired weight. The actual weight by desired weight should never exceed 1.2. If it exceeds 1.2, that means you are obese. You are overweight. So these are your 5 broad indicators for body mass index calculation, Quetelet index, ponderal, Broca's, Lorentz. These are for obesity indicators. Other indicators which may be used. So you have done is 5 indicators. Other indicators that you may use is a skin fold thickness. Skin fold thickness. Skin fold thickness is done by MCQ, Herpenden calipers. It is calculated by Herpenden calipers. It is calculated from 4 sites. From the mid triceps, mid biceps, subscapular and suprailiac. It is calculated from subscapular, suprailiac, mid biceps and triceps. Mid biceps and triceps. So all the sum of all the 4 sites, if it is more than 50 or it is more than 40 in case of males and more than 50 in case of females, that will be called as obesity. Next is another indicator we can check is the waist circumference. Waist circumference, if it is more than 102 or more than 88. 88 in case of females, 102 in case of males, it will be called as obesity. In Indian guidelines, some of the Indian guidelines, especially by the ICMR, they have said that if the weight is more than 90 and more than 80 for Indian population, it may fall as high risk for obesity. So it's a pre-obese phase or a high risk for obesity. So more than 90 or more than 80 waist circumference in Indian population. Next indicator that you need to do is last indicator, that is the waist hip ratio. The waist hip ratio. The waist hip ratio should be more than 1, if it is more than 1 for males or more than 0.85 for females. In those cases, it will be classified as obesity. More than 1 for males or more than 0.85 for females, that will be classified as obesity. Please remember, there is also a BMI cutoff for Indians. BMI cutoff for Indian population. The BMI cutoff could be for 2 different, for the global population or for the Asian population, specifically talking as Indian population. So if you talk about the BMI classification, the BMI classification under nutrition is less than 18.5. The normal BMI you need to remember is 18.5 to 24.9 or 25 in the Western world, and it is till 23. That's a very big MCQ, till 23. Less than 23 is what is we categorize in India. So now coming 23 to 25 is what is a pre-obese. 25 to 30 is what is obesity grade 1, and more than 30 is what is obesity grade 2. So these are your predictive. It is dependent on the Asia Pacific WHO guidelines formulated way back 20 years back. And these are the guidelines that we are using for cutoff for BMI in the Asian population and the Indian population. It is the BMI cutoff for Indian and Asian, which is different from the global population. In case you have not heard about something called as a thrifty gene hypothesis, where the malnutrition, the degree of malnutrition may determine the degree of obesity later on in life. So there is a kind of a hungry gene hypothesis or a thrifty gene hypothesis. So just have a look at that sometime. It will be a good knowledge bank for you that what is the cause for having different cutoffs for the Asian and for the global population. Also, another thing you would like to remember over here is what is a morbid obesity. Please remember that morbid obesity is when the BMI crosses 40. And there is something called as a supermorbid obesity. Supermorbid obesity. That is when we have a lot of food in a 5-star hotel. When you're going for a marriage party. Supermorbid obesity is when the BMI crosses more than 50. Right? So you can just remember these guidelines for your exams. Anyways, all said and done, please remember that in India, the cutoff that we take for obesity or pre-obesity or the normal range is less than 23. That is what is the take-home message over here. Next is, let's move to the topic number 4. We will talk about rheumatic heart disease or rheumatic fever. Rheumatic heart disease or rheumatic fever is one of the few diseases which has infectious etiology. It is infectious agent. It is an infectious disease, right? With hypersensitivity reaction towards some of the infectious pathogens. The most common pathogen which is implicated in causing a rheumatic heart disease or rheumatic fever is a group A streptococci, serotype M5. Gas is group A streptococci. Group A streptococci, serotype M5. You need to remember. There are other infectious agents also implicated. Example for this could be the Coxsackie virus. Coxsackie virus is also another virus which is implicated in the pathology and etiology of rheumatic heart disease. Next MCQ, what is the most common age? Most common age for happening of rheumatic heart disease is 5 years till 15 years. That is, the school-going children might develop this rheumatic heart disease. Next is, what is the most common abnormality or most common valvular involvement? The most common valve which is involved, the cardiac valve which is involved in rheumatic heart disease is a mitral valve. So for mitral valve, we may experience a mitral regurgitation or we may have a mitral stenosis. Regurgitation is specifically common in children. In children, we have mitral regurgitation. Overall, mitral stenosis and mitral regurgitation both are important. Do you know that rheumatic heart disease is also one of the most common cause of heart disease in age group 5 to 30 years? So it is the most common cause of heart disease in young population, 5 to 30 years population. Rheumatic heart disease is one of the major factors. What could be the etiology or the etiopathogenesis or the agent factors, host factors? Rheumatic heart disease is a disease which is associated with low environmental hygiene. It is associated with overcrowding. It is associated with poverty. It is associated with low socioeconomic status, overcrowding, and low environmental hygiene, all these things. The drug of choice that we give for rheumatic heart disease, for both for prevention and for prophylaxis, both for prevention, prophylaxis, and treatment. For all these things, it is a simple answer. It is benzathine, benzyl, penicillin. Given in different dosages, you have 0.6 for 0.6 million units or 6 lakh international units for the children, 1.2 million units for the adults. So for given some special time period. From community medicine point of view, for rheumatic heart fever or rheumatic heart disease, we need to remember one program, that is a Jai Vigyan mission. Jai Vigyan Mission. What is a Jai Vigyan Mission? Jai Vigyan Mission, it's a new program launched by Government of India with 4 objectives. Objective number 1 is to find out the serosurveillance, to do the epidemiological study and serosurveillance of streptococcus, group A streptococcus and sore throat. To do the serosurveillance, to find out the epidemiological determinants for group A streptococci and sore throat. The second objective of this is to do the registry of rheumatic fever and rheumatic heart disease across the country. Third is to formulate or promote formulation of vaccine development for rheumatic heart disease or rheumatic heart failure or rheumatic fever. Fourth is to promote more studies, more research and development. R&D means research and development and advanced studies to understand more in pathology of rheumatic heart disease, and more about the clinical features and advanced studies on research and development, how to diagnose better and things like this. So this is what is a Jai Vigyan Mission. It's a big mission launched by Government of India, and a lot of funds has been spent on this. Under this, we are doing a registry of rheumatic fever and rheumatic heart disease. So please remember, for assessment of rheumatic heart disease, which is the best age group for doing the prevalence. The prevalence studies which are done under this Jai Vigyan Mission are carried on in 6 to 14 years. It technically means 6 to 14 years means 5 to 15 years. Are you getting it? So 5th-year-old child, that means 6-year-old child, right? In the 5th year. So 6 to 14 year age group, we are doing this prevalence studies. It has been found, last data was somewhere in 2016-17. It has been found that the rheumatic heart disease prevalence in our country ranges from 5 to 7%, 5 to 7 per 1,000 population. So that's the burden of rheumatic heart disease. And please remember, this age group can be asked to you that under what age group are we doing and which is the best indicator for doing prevalence studies. The best indicator to study rheumatic heart disease is age group 6 to 14 years. The next topic that you need to do is something about the cancer related data and mortality indicators, and which is the most common cancer and things, and so on and so forth. Please remember that in India, CA breast, what is the best screening tool that we have? The most sensitive screening tool that we have is mammography. For CA cervix, I hope you all must have done much in detail in your gynae section, but for CA cervix at a PHC level, what is the screening tool we have? We use visual inspection method with acetic acid. So in visual VIA method with 5% acetic acid is what is used. There are different types of visual methods. You have VIM with magnification or without magnification. But please remember that at PHC level, we use visual inspection method for finding CA cervix. It is a very crude procedure, but at CHC level, we have the best screening modality. At CHC level and above. At CHC level and above, we have the best screening modality. What is the best screening modality for CA cervix? I think we all know that is the pap smears. So this is just one very basic thing I wanted to discuss with you. Now let us go ahead and talk about some of the cancer related data. Now for cancer, there is an issue this year. In 2021, there is a small issue. The problem is that what is the cancer resource data that we should be taking? So the global system, the WHO is having a Globocon data. Globocon data, that is a global cancer observatory network. Global cancer observatory network. So this global cancer observatory network is going to give us a very good amount of data, and that's what we had been using. But for cancer in year 2020, The Government of India with ICMR, ICMR stands for Indian Council of Medical Research. With ICMR, they came up with the data from the National Cancer Registry Program. From the Cancer Registry Program. So now you have two sets of data. I'm going to do both of them, but for your MCQ exam, since you are going to give an Indian MCQ exam and there might be professors who have taken part in this ICMR Cancer Registry Program, they will be asking us questions. So I think from MCQ perspective, this is more reliable as far as the data resource is there. Of course, we just got the preliminary study report, but I'll be sharing the data with you. So talking about the cancer data. So the first MCQ that may come is, which of the following is the most common cancer? So if you talk about the global population, the most common cancer across the world for both the genders, it is lung cancer. It is lung cancer. Followed by that, you have breast cancer. Followed by that, colorectal, prostate and stomach. So that is your cancer number 1. That is lung. Breast, I'll write it here. Lung, followed by breast cancer. Followed by colorectal cancer, followed by prostate cancer, followed by stomach cancer. This is the most common cancer, most common new cases in year 2018. This is across the world. If you talk about the number of deaths due to cancer, the most common cause of death, COD stands for most common cause of death. So in cancers, the most common cause of death was lung cancer, followed by that colorectal cancer, followed by that stomach cancer, followed by that liver and breast and so on and so forth. So you know this data now is pretty easy to apprehend, easy to understand that the most common cause of death in the whole world, it is a lung cancer, followed by colorectal cancer, followed by stomach cancer, followed by liver cancer, followed by breast cancer. So breast cancer, you come to know, is fairly prevalent, but it does not cause a lot of deaths as such, as far as current time is concerned. Now coming to the Indian subset from the same Globocon data. If you look at this data more closely, you can find out that the maximum cancer prevalent incidence was because of the breast cancer for both the genders. So I'm now writing it down for you for both gender, that is for both males and females. The most common cancer was found to be a breast cancer. Followed by that, we had lip oral cavity. Followed by that, cervix cancer, lung cancer, stomach cancer. So we had breast cancer, lip oral cavity, cervix uteri, lung cancer and stomach cancer, right? Are we okay with this? So now, if you go into this Indian data, you can also see that in males and in females, which is the first cancer, it is lip oral cancer, followed by lung cancer and stomach cancer. Just remember this till now. So now you take this data and compare it with the data from the National Cancer Registry Program. If I show you the data from National Cancer Registry Program, as you can see on the slide, don't get scared. Don't look at all the numbers and say that, wow, what is this? It's a preliminary data. ICMR, Indian Council Medical Research, is doing a beautiful job. This National Cancer Registry Program, it's a big program, and they are in the process of compiling, and we are thankful that they have at least given us the preliminary data. So now I'm going to compare the Globocon data, which is there in the screen, with the Cancer Registry Program, which is given now. So I have compiled this whole things for you in a very single line. So what this National Cancer Registry Program is suggesting, it is telling us, not suggesting, it is telling us the data which is generated by the Cancer Registry Program, CRP, is that in males, the most common cancer is lung. Followed by that, we have the oral cancer. Followed by that, we have the stomach cancer. And followed by that, we have the esophageal cancer. Very common things and very important. In females, you can see that the females, most common cancer is of the breast, followed by the cervix uteri. So just remember, that is where the difference lies. What is the most common cancer in males according to Cancer Registry? It is lung. Followed by that, we have the oral cancer. Are we getting it? Whereas in the Globocon data, you have the oral cancer followed by the lung cancer. That is the only difference. So don't go around haywire. Don't do confused running that teacher A tells me this, faculty B tells me this, book A is doing this, I don't know what to do. Take it easy. I have tried to show you both the things and I have spent time to compare things for you. As far as I am concerned, on my personal basis, I would sincerely recommend you to remember this data because of a simple reason that there are many people involved into this program and they must have spent a lot of time and there is a high chance of you getting a question from this area. So please remember which is the most common cancer in males as far as the cancer registry program. It is a lung cancer. In India. Lung cancer is followed by all the GI cancer. You have the oral cancer, then you have the stomach cancer, and then you have the esophageal cancer. You have the oral cancer, followed by that we have the stomach cancer, and then you have the esophageal cancer. So can you just remember this? That's all. If you can, if you want, if you are that nerdy kind of student, you would remember a Globocon data as well. But anyways, all said and done, I would sincerely say that you remember the National Cancer Registry Program. Next MCQ. 2-3 points about this National Cancer Registry Program. This National Cancer Registry Program has a purple ribbon in it. It is not a purple color. I don't know, all the females watching this video right now would appreciate it's not at all a purple color. It is a shade of lavender. So it's a lavender colored ribbon. This lavender colored ribbon is the common ribbon for all the malignancies. For breast cancer, you have pink ribbon, and for stomach, you have different. For esophageal, you have white, things and so on. So lavender is a common color. It's a common color for all cancer. It is for all cancers. So that's what this purple thing or the lavender thing denotes. Second MCQ. National Cancer Registry Program was started when? It was started in 1981 or 82. It was actually implemented in 82. It was formulated in 1981. So it is such a 38-year-old program. So since 38 years, they are doing this sites and they are checking the cancer registry sites. So under this 2020 data, what is the year they have taken? They must have taken some years. So this data, what I am showing you is from 2012 till 2016 data. And it was performed over 28 PBCRs, that is population-based cancer registries, and 58 HBCR, that is hospital-based cancer registries. What is PBCR? It's a population-based cancer registry. Cancer registry. Or we can have a HBCR, that is a hospital-based cancer registry. So these are your registry sites. And it was started in 2012-16 and the data was finally compiled this year and we are presenting to you. And this can be of MCQ of importance to us. So now let us come over and learn about the National Health Program related to the non-communicable disease. National Health Program related to the non-communicable disease. The first program you would like to know is the National Program for CDCS. What's this whole name? What's the full name of this CDCS? It is National Program for Control and Prevention. It has both the names, prevention and control of cancer, diabetes, cardiovascular disease and stroke. So that is why it is called as the CDCS program. The full name is National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease and Stroke. It's a long program. So first MCQ, what are the objectives of this program? The objectives of this program are to achieve the WHO objectives. So that means in one word, I'm going to tell you the WHO objectives for the non-communicable disease. The WHO objectives are called as the Global Framework for non-communicable diseases to be achieved by year 2025. So first is you remember this MCQ. That what is the year by which we want to achieve this? By 2025. The program is, in short, I will be writing NP-CDCS program. That is also in short we write in the government. It is a CDCS program, cancer, diabetes, cardiovascular disease and stroke. And very soon in time to come, we are just waiting for the official orders that the respiratory illnesses would also be a part of the CDCS program. So anyways, that is what is the national global framework that we have adopted. So let's learn about what is the national global framework. So the global NCD framework is kind of having 9 components. There are 9 targets and unfortunately or fortunately you need to remember those 9 targets. So it's kind of easy to remember. We divide into 2, 2, 2, 2 and 2. and last is 1, of course. So first thing is, which are the maximum high risk areas for having NCD? What do you think is the most high risk factors? The highest risk factors, the maximum risk factor is for which things? What do you think? Don't you think it is for 2 S's, that is smoking and salt? So the program wants to reduce smoking and program wants to reduce the salt intake or the sodium intake by how much? Reduce it by 30% in the community. Remember, maximum risk factor is due to smoking and salt. You want to reduce it by 30%. Next is, let us come to the other risk factors. Other risk factors. I'm not saying they are less, but they are like other. The other risk factor would be something like alcohol. Maybe it's also one of the risk factors for cancer, coronary artery disease, cardiovascular disease, stroke, and all these things. And less physical activity. Less physical activity. How much you want the reduction in these prevalence of the risk factors? We want they should be reduced by 10%. Mind it. So main risk factors 30% reduction, other risk factors 10% reduction. If you do all this, then we are going to achieve something. If we do all this, we will achieve something. What are we going to achieve? We will achieve premature deaths due to cardiovascular diseases or other diseases like cancer, diabetes, or stroke, or respiratory illnesses, right? That will be reduced. Second is, we will also reduce the blood pressure prevalence in the community, or in simple words, hypertension prevalence. Because you are targeting salt, you are targeting smoking. Because you are targeting all the major and the minor risk factors, you will be declining the premature deaths and the blood pressure prevalence in the community by how much? Our target is to decline them by 25% decline should be there. So with 30% decline in the major risk factors, 10% decline in the minor risk factors, we will obtain a 25% decline in the other risk factors, in the main diseases. That is premature deaths due to cancer, diabetes, cardiovascular disease and stroke, and respiratory diseases, and also a decline in the BP prevalence in the community. So we have done how many articles? We have done 1 component, 2 component, 3, 4, 5 and 6 components are done. 3 are remaining. 2 of them are the policy components. Which are the policy components? The policy says, the National Global Framework says that at least 80% of community should have access to MCQ affordable. The word is affordable. That's important word. Don't forget about it. It's an affordable medicines and generic medicines to be available for all the non-communicable diseases. Affordable medicines to be available for all non-communicable diseases in all areas, that is private and public areas. So in all the areas, there should be availability of the affordable generic medicines or these things. I hope you know there is an AMRIT scheme. It is affordable medicines and reliable implants for treatment. So that scheme was envisaged, it was thought to comply to the global framework for NCD. So one is this indicator, policy indicator 1, that is more than 80%. Next is at least 50% or more than 50% of the population living with non-communicable disease, they should get the access to drugs. So more than 50% of all patients with the non-communicable disease should get access to drugs and medicines to prevent what? To prevent the heart attacks and stroke. So to prevent coronary artery disease and stroke, they should get the medicines for at least 50% should get those medicines. And last policy thing is very simple. You have to halt the epidemic of diabesity, halt the epidemic of diabetes and obesity. So these, what you see on the screen right now, these are your 9 indicators. We'll repeat again. Smoking to be decreased and sodium salt to be decreased, main 30%. Alcohol to be decreased, and along with alcohol, you should have decline in the physical activity 10%. Then on the other hand, if you do all this, premature deaths due to cancer, diabetes and all these things will decrease, and also the BP prevalence in the country will decrease. So these are your 6 main things. Beyond that, all the 2 would be your policy thing, and 1 is another bigger thing. So what is the bigger thing? The biggest thing is halt the diabetes and obesity epidemic in the world, in the country. And the policy indicator is more than 80% should get affordable medicines, and more than 50% of all the non-communicable should get all the medicines, drugs to prevent heart disease, coronary artery disease and stroke. Will you remember this? So just showing you this, the national global targets to be achieved by year 2025. So it's the same thing we have already discussed. Premature mortality reduction can happen only if we have 10% alcohol and physical activity reduction. It can also happen if we have salt and tobacco intake to decrease by 30%. It will also happen if we give them the drug and if we give them the essential medicine more than 80%, and all the drugs and counseling services to be available for at least 50%. This also includes, please remember, the glycemic control. So the drugs which are oral hypoglycemic agent, that should also be at least given to 50% of people with the diabetes. If we do this, then we might achieve the 25% reduction in blood pressures, and diabetes, obesity will be halted, and the premature deaths would actually decrease. So this is what is the objective of the National Program for Control of Cancer, Diabetes, Cardiovascular Disease and Stroke. So now we come to what are the strategies under this program. Under this program, the strategies are at primary level. So next is what are the strategies under this program. If you talk about strategies under this program, we are trying to build up. This program is still coming up. It is being run in the cities, but we are trying to make it move to the rural level. So don't don't get confused if you don't find the facilities that I'm saying available in your village or in your area. The strategies under this program can be broadly put into primary level strategies. So at the primary healthcare system, that is the PHCs or below at the sub-centers, we are trying for 1 nurse to be available for every village. So every village should get a non-communicable disease specialist nurse. She will be responsible for BP monitoring in that area and for catching all the high-risk population. The second strategy at the primary level is training of the multipurpose worker, MPW training. For what? Training for the lifestyle modification and to provide counseling for non-communicable disease to halt the diabetes and the hypertension epidemics. Third is, second point, like the next strategy. So one strategy is nurse, second is the MPW. Third thing that you need to remember, we have already done that. You must have already been knowing that the GDM screening is now earlier in the phase. It is done at the first visit. At first visit, the GDM screening should be done. Why do you think we do it so early? Because a female who is gestational diabetes mellitus, she's already having hyperglycemia. So if you don't detect that hyperglycemia early, you are detecting at 24-28 weeks. If you are detecting at 24-28 weeks, there is already a substantial amount of congenital anomalies or the genetic changes which have already taken place in the baby because of a hyperglycemic fed state of the mother. So invariably, you are just diagnosing and you're not able to treat them. So to treat the babies early, macrosomia happens, so that pituitary will come down, growth hormone levels come down, the pituitary sensitization. I hope you understand from physiology, if the mother is in hyperglycemic state, the pituitary sensitization is at a different threshold level for the baby. So all these changes would all eventually happen if you detect it at 24-28 weeks. So we want the GDM screening to be early. So that's the reason it is done at below 12 weeks. So even if the female is coming on the first registration visit, at that time, we are supposed to do the GDM screening. For that, you need money. You need glucometers in place. You need glucose strips. You need training of the A&M workers. You need training of the ASHA workers. You need their disposal mechanisms of the glucose strips. And in case you find a GDM, you need insulin for them. So it's a altogether different ball game. So please try to understand. Slowly, the country is progressing towards implementation of the CDCS program. GDM screening to be done at early phases. Third thing is combining anemia and genetic diseases with national health programs. I think perfect example is the Anemia Mukt Bharat, where we have tried to do anemia, because anemia is one of the reasons for cardiac overloads in children. So anemia and genetic diseases testing, to be done in the field level. Perfect example is Anemia Mukt Bharat scheme. Next is, you already know that integration of the rheumatic heart disease into the RBSK portal. So integration of rheumatic heart disease with RBSK. You already know about RBSK. For more details, you need to watch all the MCH programs that we have covered. RBSK stands for Rashtriya Bal Swasthya Karyagram. Bal, in a Rashtriya Bal Swasthya Karyagram, you are talking of a 0 to 18-year-old kid. So for rheumatic heart disease also, it's the same age group, 5 to 15, right? So we are trying to integrate a rheumatic heart disease into RBSK portal, anemia and genetic disease with Anemia Mukt Bharat, GDM screening with the RCH program, population training for screening of non-communicable diseases by MPW trainings, and so on and so forth. So these are the strategies under this program, under this National Program for Control of Diabetes, Cancer, Cardiovascular Disease and Stroke. The next related program that you would like to do over here is the National Program for Burn Injury Prevention and Management. It's a National Program for Burn Injury Prevention and Management. The National Program for Burn Injury Prevention and Management is important to be put in place because there are a couple of burn patients which come, and there are no separate wards for the burn units or the burn units for these patients. So under this program, nothing very special. The government, of course, it's very special from the patient perspective, but from the government side, the only strategy that we are doing is to provide burn units. So burn units are now built up at all the district level, at all district level hospitals, district hospitals. These burn units would be specialized units with more than 400 square meter square area per bed. And in the burn units, there will be at least 6 beds for 100 bedded hospital. 100 bedded hospital will have at least 6 beds as the burn beds. You would also like to know what is a Haddon matrix over here. Haddon matrix is basically from occupational health or from injury reduction. It is a injury reduction strategy where you make a Haddon matrix. It is a statistical way to approach why people get accidents. So Haddon matrix was primarily defined for car crashes. So, but right now it is being used in public health where we try to understand why do accidents happen. It is a statistical measure to understand the cause of accidents. These accidents could be any XYZ accidents. So primarily we can have multiple causes. It could be human cause, which could be of many types. We can have psychological cause, we can have mental cause, we can have emotional causes, we can have social stresses, we can have so many causes, fatigue, so many things are there. Apart from human cause, there can also be environmental cause. Environmental cause, which includes the machinery failure, or you were driving a car and there was a dog which came in front, or the road was not good, or whatever, rain was falling. So environmental cause. There could also be a technical cause or a mechanical cause. Mechanical or a technical cause where you think that the reason for why an accident happened was probably because of the machine failure, the brakes failed, or whatever machine you were handling that needed repair and we could not repair it. So that would come under mechanical or technical cause. So there could be various causes, and the statistical way to approach these causes and to understand why accidents happen is what is a Haddon matrix, right? So with that, we cover most of your questions on non-communicable disease, and I think we have covered couple of questions on the National Program for Control of Cancer, Diabetes, Cardiovascular Disease and Stroke as well. Thank you so much for watching this module.